All right, if we look at this table, these are our FDA-approved bisphosphonates. We have Alendronate, which is Fosamax, Ibandronate, which is Boniva, Risedronate, which is Actonel, and Zoledronic acid, Reclast. And it used to be easy because zoledronic acid was the only one that ended in something different than onate, and that would help you remember that that's the one that was given by injection just every year, but you will see that things like Boniva now have also been okayed to give in IV formulation. So just remember, depending on how you give a drug, is going to tell you what the side effects will be. If it is taken by mouth, the main things will be GI effects. These are quite severe, though, when we think of drugs for osteoporosis. You will see that there is a slight, too strong association with esophageal cancer. There are some ways to prevent the progression of just GI upset into full-on metaplasia, dysplasia, neoplasia, so we'll get there. So here on just slide 27, which is where I'm starting, is the basics of the drugs. And if we go to slide 28, just like we said before, that they all do the same thing. And they don't make bones stronger. They don't fill in extra bone as we would like them to, ideally. They just limit bone resorption, which remember is the osteoclast activity. So the hydroxyapatite binding sites, they are part of the general substance associated with bones, and it helps create this nice crystalline formation so that they are strong and have integrity, and hydroxyapatite is something that is helpful. It is also somewhere that these osteoclasts can bind, form their ruffled border, release their hydrolytic substances so that they can start to break down this bone, liberating it into the bloodstream. Okay, drugs are also thought to limit the apoptotic ability or the apoptosis that you would see on osteoblasts. Remember, that's usually under the control of estrogen. It helps limit that caspase enzyme from allowing osteoblasts to undergo apoptosis. So the thinking is that this does have a protective mechanism against that in the same way that estrogen would. So going on, one other thing I want to just keep in mind for you all, there's a couple of other things that can be treated with bisphosphonate use. So one of them is chemotherapy. So in cancer-related things, when people have bone cancers or other types of chemotherapy-induced bone changes, we can give these bisphosphonates to individuals to try to prevent a lack of bone. Another thing you'll see this in is Paget's disease, and Paget's disease, it's not Piaget or Paget, it's Paget's, and Paget's is an interesting disorder where you have an overgrowth of bone, so you have essentially too much kind of osteoblast or kind of unmatched osteoclast, osteoblast activity where there is some breakdown of bone, but then there's too much osteoblast activity. So Pagetic bone is bone that is highly irregular, it's very, very thick, and it is essentially caused by too much osteoblast activity, which you see in these bones, so fibia and tibia down here at the bottom. Here's this nice normal bone, and then in Paget's disease, you have a highly abnormal tibia. And we have a lytic area and a sclerotic area. And if you remember, sclere means to harden, so sclerosis is the development of hardening, which would be bone deposition or osteoblast activity. So sclerotic area indicates areas of really thick bone, telling you there's too much osteoblast activity. And down here we have lytic bone, and lytic comes from lysis, which means to break apart. And that's the osteoclast's job. It's their activity that should break down bone. And remember, when everything's working perfectly, when osteoblasts and osteoclasts, break down bone and fill in missing pieces, it should look nice and healthy. In Paget's disease, disease, you have this overactivation of osteoclasts and overactivation of osteoblasts, and then this all over kind of pagetic abnormal bone structure. So this can appear in multiple different bones, but Paget's disease kind of rule of thumb is that it's usually just one bone at a time. You can see this in the skull. So here's this kind of sclerotic area and then lytic area associated with the skull. There's also quite a bit of calcification that you see here, kind of by the meningeal border. So that would be typically asymptomatic. And one fun fact is that your head doesn't change size. So if you have a small hat size, you should expect that throughout your life, I mean, obviously your haircut will change based on how fashionable you choose or choose not to be, will alter the size of your hat just because there's either a ton of hair or not. But the overall size of your head is pretty static. In Paget's disease, one of the ways people know that it's affecting them, especially in the skull area, is that they'll go in to buy a hat and they'll need a larger size. And they're thinking, well, I must be extra smart, but your brain doesn't grow and cause osteoblast activity. In this case, it's just osteoblast overactivation. If it becomes so heavy, so already our head weighs like 10 pounds and our neck becomes stressed from holding that up all day, if it's too heavy, you can actually develop this bowed posture where we're kind of stretching at the neck and pitching the gravity forward to kind of be looking down because the head is heavy and the neck starts to fatigue. If this is really bad, it would impede the normal blood flow that's either through these long bones or through the bottom of the skull, which can cause ischemic changes to the tissues that are expecting that blood and oxygen, or it can just create a high afterload environment in the body where the heart has to pump really hard to make it through these abnormal or narrowed or what we call sclerotic areas of bone or vessel configuration. And then the heart, when it has to beat too hard for too long, that's called high output heart failure. So it's kind of like driving a car forever, every day. It just is going to wear out eventually. So by limiting osteoblast activity and osteoclast activity and in a balanced form with Paget's disease, that does actually have good cardiovascular outcomes. So we've got cancer, we have Paget disease, and then primarily we have osteoporosis that bisphosphonates are used for. So the first medication's Alendronate, that's sold as Fosamax, and Fosamax can be taken by mouth. It typically is. There are different formulations where you don't have to take it every day, but it's used for pretty much everybody. Osteoporosis in men, for women, those people who are on chronic corticosteroids like a prednisone treatment because of an autoimmune disorder or some other type of marrow disorder where you're making too much red blood cells like polycythemia, Paget's disease, which we just mentioned. So the dosages, depending upon that person's GI health and their swallowing ability, it can be liquid or tablet. Osteoporosis, the typical dosing is either 5 mg, so up here there's like a 70 mg, like once weekly dose, but if it's once a day, it's much smaller than that. Look at that, max dose, 10 mgs. This dose up here, 70 mgs for a week. 70 days in a week, people. Math is all around you and will help you do well in life. So once a day, 5 mgs or 10 mgs, or if it's once a week, 35 or 75 mgs, that it's just one very slow release tablet taken on an empty stomach so that there's not a lot of stomach acid creation. Paget's, that's pretty intense. So the Paget's dose is 70 mgs one time a day. So it's a really, really large dose to affect these osteoclasts so that we don't get osteoblasts causing more of this sclerotic bone. Side effects, you will see if we just look, well, there's one that's abnormal here, but if we highlight all of these, damage to the esophagus, which is called esophagitis, inflammation of the esophagus, abdominal pain, acid reflux, nausea, dyspepsia means upset stomach, constipation, and or diarrhea. Those can happen at the same time. It's called alternating. In constipation, those hardened pieces of fecal matter called fecaliths move really slowly, and diarrhea can move right around it. So that's how it's alternating. There can be musculoskeletal pain because you're actually affecting these cells that are typically working on the bone, and flatulence is obviously going with your GI, so they're passing gas. And then photosensitivity, so the skin or the eyes might be more sensitive to sunlight than they typically would be. So keep these GI effects in mind. Okay, then we have Ibandronate, which is sold as Boniva or Didronel. Boniva, if we go back to the slide with Sally Field on it, and she's like, I help Boniva to help my osteoporosis and strengthen my bones. That might help you remember that Sally Field is a lady and it is used primarily in women. The only time you'd see it used in men is Paget's disease. So, dosages are oral. It could be a tablet. It can be taken once a day in a 2.5 mg dose, or it can be taken 150 mgs one time a month. So I just want to go back here to this table too. If we look at Boniva, I do want you to notice that just pretty recently they did say that this was okay to give IV, where our phosphate that or Fosamax we just looked at is oral only. So Boniva, we have IV, and you can have 3 mgs every 3 months in an IV formulation. So it's just 4 times a year rather than taking something every day. When people get their injection, they get flu-like kind of symptoms, headache, definitely pain at the site of injection, but also pain in the bone, muscle, or joint has been reported as well. Again, the side effects are mainly going to be GI, so nausea, stomach pain, diarrhea, constipation. We're also now adding in the weakness, dizziness, headache. So that tells you there's some sort of central nervous system effects. Fever, sore throat, chills. This is associated with flu-like symptoms. Frequent painful urination. Why do you think that might be? Well, I will tell you, when you're taking things and you're also taking calcium and vitamin D with it, and we're getting an alteration in osteoblast and osteoclast activity, you might remember what stone is made out of calcium, and hopefully you do right now as I'm saying it, it is the kidney stone. So if kidney stones are there, you get urinary stasis, which means your urine can't move. The rule of urine is that it is sterile as long as it's moving, but if it's not moving and it's just sitting there in the bladder, it makes gas, which means you fill up your bladder with gas so that your bladder thinks it's full. And then your detrusor muscle contracts. And then you think you have to urinate, even though there's not a lot of urine in there. When you do pass urine, there's a chance that there's calcium crystals in it. So these stones don't have to be big, 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 but they can be pretty small. And when they are passed, they are extremely painful. There is also a case, especially with Paget's disease, because it's interrupting this kind of interaction between osteoblast and osteoclast activity, that just in the same way with rickets, we see this change to the femurs because of the weight-bearing activity there. When patients are taking this drug, especially the really high doses of it, like the 150 a month, or they're getting the injection, when they report a dull aching pain in the hips, groin, or thighs, those are areas that are associated with the main breaks in osteoporosis. You can see broken thigh bones in this case, because if you don't have good osteoclast activity, you also don't have good osteoblast activity because they work together. So that can be a case. If they report pain, please tell them to stop taking that medication. Call their primary care physician, say, this is probably going to affect their femurs. Let's get them on something else. Because we didn't see that before with Fosamax. So Boniva, even though fun songs will go along with it, and Sally Field also, can get your thighs broken. So let's try to stay away from that. Then we have Risedronate or Actonel. So Actonel, this isn't just women only, this is back to everybody. So osteoporosis in men, women after menopause, your glucocorticoid related things, and Paget's. Oral, we've got tablet or delayed release. So if it's daily, it's 5 mgs a day. If it's weekly, it's 35 mgs one time a week. That's for men who are typically taking it this once a week. Remember, men are a little bit different than females because they resist fractures. So women, we want to hit with either a daily dose or a pretty large once a month dose. Once a month would be 150 once a month. All right, once again, most of the things we're going to see are associated with GI disorder, stomach upset, this heartburn, and GI tract abnormalities. Also going to flatulence, weakness, feeling dizzy, leg cramps. Remember, calcium, in the same way that too little potassium causes leg cramps, your leg cramped and somebody said, eat a banana. Sodium and potassium are opposite. They're in opposite places. So if you have low potassium, that means you have high calcium. So when people eat a lot of calcium or have a lot of calcium in their bloodstream, they can have muscle cramping because the nerves become overactive. We'll talk about that in the next chapter. Back pain, that's not really back pain. Remember, what's back there goes along with this. If you have lower back pain, it could be referred pain from the kidneys because you have kidney stones in them, leading to bladder infections and painful urination. Once again, you have the ability to possibly have broken femurs. This wouldn't be like an extreme spiral fracture. This would be like a stress fracture that could lead to something more serious. So if patients do, again, report that in that area, then you want to suggest to their primary care, or if you're the one prescribing, that they should switch to something else. Okay, finally, we have zoledronic acid sold as reclassed. And I want you to notice this one is up here as an injectable. So we've got 5 mgs dissolved per 100 milliliters. That's the way we titrate doses, so we can give a big dose in a small amount of injectable. This is for everybody, so osteoporosis in men and for women, glucocorticoids, Pagets, lots of calcium in the blood from chemo, and primarily reclassed as IV. You can give it other ways. So if we go back up here, we just see IV. You can sometimes give these IM. That would be very bizarre. I want you to think IV. We all know not everybody follows the rules and people do weird things, but I want you to know that ideally we want it given IV. For osteoporosis, it's an injection every 2 years. So if you have a patient who hates taking pills every day, with difficulty swallowing, who have hard time accessing care, who don't have great transportation or live in more rural areas, this is something just every 2 years they need an injection. Pagets, once a year. That's great. Cancer, still once every 3 to 4 weeks. So this is the least amount of patient kind of input. They have to do the least amount of work to get the treatment from this. Side effects from zoledronic acid, mainly what you see with injectables, so itching, redness, pain, swelling at place of injection. Flu-like symptoms also, so red, swollen, itchy, teary eyes, swelling around the eyes. Your GI stuff too, even though it was IV. So keep that in mind. Just because you injected it, these drugs are special. They do weird things. Constipation, nausea, vomiting, diarrhea, loss of appetite, weight loss, heartburn, mouth sores. Weird. Let's get to that in a second. Feeling kind of anxious, agitated, depressed, not sleeping normally, having other signs of infection, white patches in the mouth, which is usually a sign of mononucleosis or a thrush. So you are getting a little bit of immune suppression with this because it is affecting us. So think about it this way. If you don't have as many osteoclasts binding and doing their job, eventually the body is going to shift activity away from making osteoclasts. That means overall the marrow is going to not be as active, so you can have immunosuppression in other ways. Get that? All right, we can talk about it later if you don't. Here's the important stuff I don't want you to forget. There is an ongoing phase 5 continuing investigation with bisphosphonates in esophageal cancer. So this was a retrospective study, meaning that when they were looking at data associated with people who had esophageal cancer and were trying to draw connections between what they were doing that predisposed them to get that, like why them? What they found is people who were taking oral bisphosphonates and had at least 10 prescriptions. So that's not very much. That's not even a year. 1.93 times as likely, so that's like 2 times as likely to have had esophageal cancer. So there is a really strong association with just inflammation of the esophagus. And remember, when we think about cancer, it's just a cell that's bad that then makes copies of itself. And cells become abnormal when they're exposed to irritation. So when people have constant heartburn, constant reflux of acid here, these cells will start to change into different cells that look more strong. We call them stratified cells. Those are now what we call metaplasia or metaplastic cells. Meta means change. So those cells have undergone a change. So if you have a cell that's changed, splitting and making a copy of itself, there's a higher likelihood that that copy is not going to look like the original esophageal cell we want it to. There's more of a chance of an error, which means it can become precancerous, or what we call dysplasic. And eventually that can become full-on neoplastic, which is a new growth or cancer. So anything that causes esophagitis can cause esophageal cancer if the irritation isn't removed. Knowing that these pills cause esophagitis is important. So on slide 35, these are some things you can print these out when you give them to people if they are taking these drugs. These are simple things that can help people tie together the physiology that you know with some directions how to take their drug most safely. So take it just after you get out of bed in the morning. Don't eat or drink anything. Don't take it at bedtime. So when you get up, chances are you're going to be, standing for a while, ideally, right? You get up, you shower, you start your day, you do whatever you need to do. When you are laying down, your stomach is pressed down by any adipose tissue or pillows, which raises the pressure in your stomach, making it more likely the acid's going to go into your esophagus. All right, so instead of drinking anything, eating anything, when you take your pills, take some water, nothing else, just water, plain water after you take Alendronate, for example. Don't take them with tea, coffee, juice, milk, mineral water, sparkling water, any other liquid other than water. That is because anything else, any of these things, even though they are delicious, they increase the amount of acid your stomach makes, which makes it more likely you're going to have heartburn and then eventually have an ulcer, esophagitis, etc. Swallow the tablets whole because that's the way they're designed to work with your stomach chemistry. Don't split, chew, or crush them. Don't suck on them. That would be disgusting. They would taste terrible, but that would really alter the chemistry in your stomach, making it more likely that you're going to have heartburn. After you take your medication, do not eat, drink, or take anything else, including vitamins or antacids. A lot of vitamins make you feel pukey, like iron and stuff. That's because you need a lot of stomach acid to degrade them. Antacids, which we talk about in the next chapter, those make you feel good in the meantime. Like a Tums, it raises the pH in your stomach, so you feel nice and you don't, it doesn't burn anymore in your esophagus. But once there's a message in your intestines about what the pH was in your stomach contents, the cells there say oh man, I was expecting to get a pH of 3. This dude gives me a pH of 7 with all that stuff he just ate. I know what I'll do. I'll make more acid. And that's called rebound reflux. That means your reflux is even worse now than it was before. So antacids don't help. They make this more likely. Don't lie down for at least 30 minutes after you take it. Sit upright until 30 minutes have passed. We just want to make sure we're doing everything possible to prevent this drug from going up into the esophagus. If they do take it at night because they forgot to take it during the day, sleep on your back, put some pillows up. Very important to avoid esophageal cancer. Other serious effects, keep these in mind. So we talked about esophageal cancer. These are the first four. Worsening heartburn, difficulty swallowing, painful swallowing, upper chest pain. If any of those occur, we want to talk to the primary care physician and get a plan to switch meds or do something else to avoid the development of esophagitis and then esophageal cancer. The next three are not as serious, but they're definitely not cool. Painful swollen gums, loosening of the teeth, numbness or feeling heaviness in the jaw. Oh, why is that? Well, sometimes your, gums get swollen when you don't floss and then you put something on them, they bleed a lot. That's how the dentist knows you're lying about flossing, because your gums are going to bleed. If you have really bad heartburn, the stomach acid goes into your mouth, you start to see that the gums become swollen and painful. In this case, because of the weird activity of the osteoblast and osteoclast, you get this terrible side effect called osteonecrosis of jaw. That means the development is osis. The development. Necro is death. Osteo is bone. So the development of dead bone of the jaw. And this is very severe. This has gone on for quite a bit, but this begins with having teeth that get loose and then fall out. And the reason they're falling out, and you can't see it yet because the gum is still there, is that the jaw bones are starting to die. So here, edentulous maxilla displaying exposed necrotic bone. Note the receded mucosa. See this white-looking stuff? That's supposed to be your mucous membranes. So you don't have to let people get to this point. This is a cool picture, but when the teeth get loose, when the gums get sore, you try to get them off of that medication so that their bone doesn't die and then their teeth fall out, and then they have this to deal with. Because in this case, they're not just going to pat them on the back and let them go. They're going to have to remove that necrotic bone, and that's going to be a very severe surgery. So remember that. Drug interactions, there is a synthetic parathyroid hormone called Forteo. So remember, PTH causes osteoclast activity, right? Because it means your calcium's too low. Don't mix that with Alendronate. That's going to mess your stuff up. Postmenopausal women that have taken Alendronate and Forteo have decreased effectiveness in bone strength. When men take it together, it decreases the effectiveness of parathyroid hormone.